Adrenergic agonist, Chapter 17. Adrenergic agonists are often referred to as sympathomimetics. Adrenergic agonists have a broad spectrum of indications, ranging from heart failure to asthma to preterm labor. Drugs can activate adrenergic receptors by four basic mechanisms. Only the first method is direct. The other three stimulate indirectly. Number 1, direct receptor binding. Number 2, promotion of norepinephrine release. Number 3, blockade of norepinephrine reuptake. And 4, inhibition of norepinephrine inactivation. The direct receptor binding is the most common mechanism by which drugs activate peripheral adrenergic receptors, and they produce their effects by binding to adrenergic receptors and mimicking the actions of natural transmitters. These are norepinephrine, epinephrine, and dopamine. In this chapter, our main focus will be on direct receptor binding, with the exception of ephedrine, which is a drug that works by combination of direct receptor activation and promotion of norepinephrine release. The adrenergic agonists fall into two major chemical classes: catecholamines and non-catecholamines. They differ in three very important respects. Number 1, the oral usability; 2, duration of action; and 3, ability to act in the central nervous system. Catecholamines such as epinephrine, dopamine, and dopamine cannot be used orally. This is due to the actions of two enzymes, monoamine oxidase, or MOA, and catechol O-methotrexferase, or COMT. They are located in the liver and in the intestinal wall, and they destroy catecholamines administered orally. They have a brief duration of action, and they cannot cross the blood-brain barrier, so they have a minimal impact on the central nervous system. Non-catecholamines, such as ephedrine, albuterol, and phenylephrine, can be given orally. They are metabolized slowly by MOA, therefore non-catecholamines have a longer half-life, and they are considered less polar and hence are more able to cross the blood-brain barrier. To understand the actions of the individual adrenergic agonist, we need to know their receptor specificity. Sympathomimetic drugs differ widely with respect to the receptors they can activate. The ability of a drug to selectively activate certain receptors depends on the dosage. At low dosage, selectivity is maximal. As dose increases, selectivity declines. For example, when albuterol is administered into low to moderate doses, the drug is highly selective for beta-2 adrenergic receptors. However, if the dosage is high, albuterol will activate beta-1 receptors as well. First, we will talk about the clinical applications of activation of alpha-1 agonist. Drugs capable of activating alpha-1 receptors include epinephrine, norepinephrine, phenylephrine, ephedrine, and dopamine. Activation of alpha-1 receptors elicits two responses that can be of therapeutic use. 1, vasoconstriction in the blood vessels of the skin, viscera, and mucous membranes, and mydriasis. Alpha 1 agonists are useful most often for vasoconstriction and rarely for mydriasis. Therapeutic applications of alpha 1 activation include homeostasis, and this is defined as the arrest of bleeding and is accomplished via vasoconstriction. Topical epinephrine is used most commonly for this purpose. 2. Specific alpha 1 activating agents used as nasal decongestants can relieve congestion by causing alpha 1 mediated vasoconstriction. These include phenylephrine applied topically and pseudoephedrine taken orally. Number 3. Because of their ability to cause vasoconstriction, alpha 1 agonists can elevate blood pressure in hypotensive clients. However, they are not the primary therapy for hypotension. Number 4. Activation of alpha 1 receptors on the radial muscle of the iris causes mydriasis, or dilation of the pupil, which can facilitate eye examinations and ocular surgery. 5. Alpha 1 agonists are frequently combined with local anesthetics to delay anesthetic absorption. The drug used most frequently is epinephrine. Adverse effects of alpha 1 activation, all directly or indirectly related to vasoconstriction. Hypertension. Alpha 1 agonists can produce hypertension by causing widespread vasoconstriction. It is most likely with parenteral dosing. Client must be monitored continuously. Necrosis. If the IV line becomes extravasated with an alpha 1 agonist, local seepage of the drug may result in necrosis. Phenethylamine, an alpha 1 blocking agent, should be infiltrated into the area, which will counteract alpha 1 mediated vasoconstriction and thereby help minimize injury. Bradycardia. Alpha 1 mediated vasoconstriction elevates blood pressure, which triggers the baroreceptor reflex, causing bradycardia. Alpha 2 receptors in the periphery are located presynaptically, and their activation inhibits norepinephrine release. Their ability to activate these receptors in the periphery has no therapeutic applications. However, activation of receptors in the central nervous system has clinical significance. By activating central alpha 2 receptors, two useful effects are produced. 1. Reduction of sympathetic outflow to the heart and blood vessels, and number 2, relief of severe pain. All clinically relevant responses to activation of beta 1 receptors occur in the heart. These receptors can be activated by epinephrine, norepinephrine, isoproterenol, dopamine, dopamine, and ephedrine. Therapeutic applications of beta 1 activation include cardiac arrest, heart failure, shock, and atrioventricular heart block, or AV block. All of the adverse effects of beta 1 activation result from activating beta 1 receptors in the heart. Number 1, they include altered heart rate or rhythm due to overstimulation, producing tachycardia and dysrhythmia. And number 2, in some clients, beta 1 activation can precipitate an attack of angina pectoris. Clients with compromised coronary circulation are at risk of an anginal attack. Therapeutic applications of beta 2 activation are limited to the lungs and the uterus. Drugs used for their beta 2 activating ability include epinephrine, isoproterenol, and albuterol. The therapeutic benefits include promoting bronchodilation to relieve or prevent asthma attacks. Most beta 2 agonists used to treat asthma are administered by inhalation. The preferred beta 2 receptor drug is albuterol. Activation of beta 2 receptors in the uterus relaxes uterine smooth muscle, delaying preterm labor. The most important adverse response to beta 2 activation is hyperglycemia. If hyperglycemia develops in the diabetic client, insulin dosage must be increased. Tremor is the most common side effect. Activation of peripheral dopamine receptors causes dilation of the kidneys. The effect is exploited in the treatment of shock. By dilating renal blood vessels, renal perfusion is improved, reduces the risk of renal failure, and also enhanced cardiac performance. Remember, dopamine is the only drug that can activate dopamine receptors. Anaphylaxis is a serious allergic response. It is characterized by hypotension, bronchoconstriction, and edema of the glottis. Epinephrine injected IM is the treatment of choice for anaphylactic shock. Epinephrine injected IM is the treatment of choice for anaphylactic shock. Adrenergic agonists include epinephrine, norepinephrine, isoproterenol, dopamine, dobutamine, phenylephrine, albuterol, and ephedrine. Epinephrine can activate all four subtypes of adrenergic receptors. Therefore, it can produce a broad spectrum of beneficial sympathomimetic effects. Therapeutic uses include delays absorption of local anesthetic, controls superficial bleeding, elevates blood pressure, mydriasis during ophthalmic procedures, and this is not used in the U.S., overcomes AV block, restores cardiac function in arrest, bronchial dilation in asthma, and treatment of choice for anaphylactic shock. Epinephrine can be administered topically or by injection. It cannot be given orally because epinephrine and other catecholamines are inactivated in the GI tract. It has a short half-life. Adverse effects include hypertensive crisis, therefore therapy requires constant monitoring. Dysrhythmias, hypothyroid clients are at higher risk for epinephrine-induced dysrhythmias. Angina pectoris is likely in clients with coronary atherosclerosis. Necrosis may result if an IV line containing epinephrine becomes extravasated. And in diabetic clients, epinephrine can cause hyperglycemia. Drug interactions with epinephrine include MOA inhibitors, tricyclic antidepressants, general anesthetics, alpha adrenergic blocking agents, and beta adrenergic blocking agents. Preparation, dosage, and administration of epinephrine include EpiPen, box 17-1, page 158, IV. Remember, if you're going to give epinephrine IV, we need to monitor that patient very closely. It can be given IM, sub-Q, intracardiac. This is rarely used, only in asystole if IV is not available. Intraspinal, inhalation, topical, and see Table 73 for the different concentrations for the different routes. Norepinephrine receptor specificity include alpha 1, alpha 2, and beta 1. Norepinephrine's chemical classification is cholecylamine. Therapeutic uses in hypertensive states and cardiac arrest. Norepinephrine differs from epinephrine only in that norepinephrine does not activate beta 2 receptors. Norepinephrine does not promote hyperglycemia. Responses to norepinephrine can be modified by MAO inhibitors, tricyclic antidepressants, general anesthetics, and adrenergic blocking agents. Isoproterenol acts only at beta adrenergic receptors, beta 1 and beta 2. The clinical classification is catecholamine. Therapeutics used include cardiovascular, asthma, and bronchospasm. Isoproterenol adverse effects are fewer than those of norepinephrine or epinephrine. They include tachydysrhythmias, angina pectoris, and hyperglycemia. Drug interactions are enhanced by MAO inhibitors and tricyclic antidepressants, and reduced by beta adrenergic blocking agents. Administration IV, IM, and intracardiac injections. Dopamine receptor specificity is dose dependent. At low therapeutic dose, dopamine acts on dopamine receptors. At moderate therapeutic dose, dopamine activated beta 1 receptors in addition to dopamine receptors. At a very high doses, dopamine activates alpha 1 receptors along with beta 1 and dopamine receptors. The chemical classification is catecholamine. Therapeutic uses include shock, heart failure, and acute renal failure. Dopamine is used in shock because it can dilate renal blood vessels, thereby improving renal perfusion. Success is evaluated by monitoring urine output. Success is evaluated by monitoring urine output. The most common adverse effects are tachycardia, dysrhythmias, and anginal pain. Necrosis can occur with extravasation. MAO inhibitors can intensify the effects of dopamine. Tricyclic antidepressants can also intensify dopamine's actions, but not to the extent seen with MAO inhibitors. Certain general anesthetics can increase the risk of dysrhythmias. Diuretics can complement the beneficial effects of dopamine in the kidneys. Concentrated solutions of dopamine must be diluted prior to infusion. It is administered by IV continuous infusion, and the patient must be closely monitored. Dopamine receptor specificity is beta 1. The chemical classification is catecholamine. The only indication for dopamine is heart failure. The major adverse effect is tachycardia. Blood pressure and ECG should be monitored very closely. Effects of dopamine on the heart and blood vessels are intensified greatly by MAO inhibitors. Certain general anesthetics can increase the risk of dysrhythmias. Dopamine is administered by continuous IV infusion. The usual rate is 2.5 to 10 micrograms a kilogram a minute. Again, we must monitor this patient very closely. Phenylephrine receptor specificity is alpha 1. The clinical classification is non-catecholamine. It is administered locally to reduce nasal congestion and parenterally to elevate blood pressure. In addition, phenylephrine eye drops can be used to dilate the pupil. Phenylephrine can be co-administered with local anesthetics to retard anesthetic absorption. Albuterol's receptor specificity is beta 2. The chemical classification is non-catecholamine. Albuterol can reduce airway restriction in asthma by causing beta 2 mediated bronchodilation. It produces much less activation of cardiac beta 1 receptor than does isoproterenol, therefore has replaced isoproterenol for therapy of asthma. Albuterol produces much less activation of cardiac beta 1 receptor than does isoproterenol, therefore has replaced isoproterenol for therapy of asthma. Adverse effects are minimal at therapeutic doses. Tremor is most common. If doses is excessive, albuterol can cause tachycardia. So what have we learned? After an intramuscular injection of penicillin, a patient develops severe difficulty breathing and a swollen tongue. Which medication should the nurse prepare to administer? A. Dopamine. B. Epinephrine. C. Norepinephrine. Or D. Pseudoephedrine. If you chose B. Epinephrine, you are correct. Epinephrine is the drug of choice for patients in anaphylactic shock. Epinephrine is the drug of choice for patients in anaphylactic shock. Let's see what's next. A patient is receiving dopamine for the treatment of shock. What would indicate to the nurse that the medication is effective? A. Decreased mean arterial pressure. B. Gain of 2 kilograms in 24 hours. C. Increased heart rate. Or D. Increased urine output. If you chose D. Increased urine output, you are correct. Dopamine is used for the treatment of shock. Improved clinical status will best be monitored by assessing the patient's urine output. Dopamine will dilate renal blood vessels, improve renal perfusion, and increase urine output. Let's try another one. A patient is started on a dopamine infusion for the treatment of acute decompensated heart failure. The nurse should assess the patient for the major adverse effect of dopamine therapy, which is A. Supraventricular tachycardia. B. Fine hand tremors. C. AV heart block. D. Hyperglycemia. If you chose A. Supraventricular tachycardia, you are correct. Dopamine causes the selective activation of beta 1 adrenergic receptors, and it is indicated only for the treatment of heart failure. The major adverse effect is tachycardia. Let's try one more. The nurse cares for a patient with asthma who uses an albuterol metered dose inhaler. The nurse is most concerned if the patient makes which of the following statements? A. The medicine in the inhaler helps me to breathe. B. I can use the inhaler as often as needed. C. My hand starts to shake after I use the inhaler. And D. If the inhaler doesn't work, I should dial 911. So what is the nurse most concerned about? If you chose B, I can use the inhaler as often as needed, you are correct. Albuterol can reduce airway resistance in patients with asthma by causing beta-2 mediated bronchodilation. If it is administered in large doses, albuterol will lose selectivity. It will activate beta-1 receptors as well as beta-2 receptors. Accordingly, patients should be warned not to exceed the recommended dosage because doing so may cause tachycardia by activating beta-1 receptors in the heart. Trauma is a common adverse effect of this drug.